Welcome back to my new video in my channel, and today I'm presenting to you the part 3 and the final and the concluding part on the ICU acquired weakness, which is a continuation of the last video. So here there's a snapshot of differentiation between the critical illness polyneuropathy features and the critical illness myopathy features based on the CMAP amplitude, the CMAP duration, SNAP amplitude, the nerve conduction velocity, EMG at rest, and all sorts of neurological kind of parameters. But I think I'll just move on to the next slide, and in very short, I can tell you that in critical illness polyneuropathy, you can have a normal to minimally reduced nerve conduction velocity, the reduced CMAP amplitude, and CMAP stands for compound muscle action potential, and reduced compound snap amplitude, that is the snap stands for sensory nerve action potential. Whereas in myopathy, you can have the same features except that it has normal snap. So these are the differentiating factor. Whereas in critical illness polyneuropathy, you will have a reduced snap amplitude, whereas in critical illness myopathy, you will have a normal snap. So this is very important and very easy to remember. As far as the diagnosis of the ICU acquired weakness is concerned, you can have a volitional functioning testings and non-volitional functional testing and the imaging. Again, I think it is a busy slide, and I'll go ahead and just tell you that the muscle biopsy is a definitive diagnosis for muscle involvement, and you can find a muscle fiber atrophy, especially the type 2, occasional fiber necrosis, regeneration, and decreased or absent reactivity in myofibrillar ATP staining. There is loss of myosin, which is pathognomic feature for CIM, that is critical illness myopathy. So this is what you can remember. At the same time, if you compare CIP, CIM, and critical illness and neuromyopathy, so you have a direct muscle stimulation. So you have a nerve to muscle ratio 0.5 and reduce the normal direct muscle CMAP amplitude. Whereas in CINM, you have a variable depending on the relative components of CIP and CIM. In muscle biopsy, you can have features of denervation and renervation in CIP, whereas you have cachectic myopathy with myofibrillar degeneration and thick filament myopathy with a selective loss of myosin filaments in CIM, and there could be both features of CIP and CIM in CINM. The same thing is with nerve biopsy. You can have normal or motor and sensory nerve axonal degeneration in CIP, and you can actually have a normal nerve biopsy in CIM. So which is very clearly understood. CPK, in of course it can be elevated in CIM, that is critical illness myopathy. CSF, which can be normal in almost except that the slightly elevated protein levels in all the three, except of course in CIM it would be absolutely normal. Nerve conduction studies, there are reduced CMAP. We have just seen that how you can differentiate between the critical illness polyneuropathy where you have a reduced snap, whereas this critical illness myopathy where there could be normal snap, and this is what we discussed just now some time back. So what are the differentials of weakness in ICU? As far as muscles are concerned, we look at medications, the undiagnosed kind of neuromuscular disorder, and this is a mnemonic actually, muscles. So DT of weakness in ICU, and very easy to remember, is muscles. So this is a mnemonic. M stands for medications, U stands for undiagnosed neuromuscular disorders like myasthenia, inflammatory myopathies, mitochondrial myopathies. S stands for spinal cord diseases related to or caused by ischemia, compression, trauma, vasculitis. C stands for critical illness, myopathy or polyneuropathy. L stands for loss of muscle mass, like in cachectic myopathy or rhabdomyolysis. E stands for electrical imbalances or abnormalities, hypokalemia, hypophosphatemia, and hypermagnesemia. And of course, S stands for systemic illnesses like porphyrias, AIDS, vasculitis, and paraneoplastic syndromes or toxins. So, I think this is an important slide of my entire talk, is when it talks about a whole lot of list of differential diagnosis, and very simply and easily you can remember by remembering this mnemonic as muscles. How do you prevent? You need to minimize the risk factors, intensive insulin therapy, avoid hyperglycemias, and of course electrical muscle stimulation. Rehabilitation, extremely important. Early mobilization of patient in ICU, very important. So you need to take care of prolonged bed rest, immobilization, inactivity, preventing bed sores, compression neuropathies, joint ossifications, deconditioning, and low mood. And you undertake the incremental level of activity, the physical activities, and of course physiotherapy. So this forms an extremely important cornerstone of prevention of this deadly problem. And there are definite benefits of early rehabilitation program which are seen and which will actually minimize the complications of bed rest. It will facilitate the weaning from ventilatory supports. It will reduce the ICU length of stay, reduce the hospital length of stay. It will promote the improved functioning and improve the quality of patient's life. It can actually save the cost without any adverse outcomes. So these are the short-term complications, and we have seen that this can cause high hospital mortality, length of stay, extubation failures, and long-term it can have post-ICU mortality, physical functioning, and the rehabilitation which is not there. So there is no proven treatment for this. You need to treat the underlying cause, treat and prevent the complications, and of course rehabilitation, which forms the mainstay. So of course it is an independent risk factor for increased duration of mechanical ventilation, weaning failure, ICU and hospital length of stay. It will cause about 45% mortality within their hospital admission, and 20% die in the first year of discharge, and a huge morbidity thereupon. So ICU acquired weakness is a common cause of prolonged mechanical ventilation and delayed return to physical activity. There is a lack of standard diagnostic criteria. The number of risk factors associated with development of weakness during critical illness. Treatment is largely supportive. You need to treat the cause, and more aggressive use of physiotherapy, early mobilization, ambulation, which leads to better outcome. So it is a major contributor to functional impairment. It has slow and incomplete recovery. We need aggressive treatment of conditions like sepsis. Avoid hyperglycemia, early mobilization, intermittent and minimal sedation, sedation interruptions, and multidisciplinary care. So as this happens in my ICU, where this patient, even on mechanical ventilator, as you could see, that he is made to walk, and that is the whole purpose of this teaching programs, where I need to actually emphasis upon early mobilization, come what may, whenever possible, with the slightest window which we get as an intensivist, you can find the phenomenal results. I think I'll stop here with a positive note that a sick patient who was sitting started walking, even on ventilator in my ICUs. It is very often and very frequent sight. So with this I'll stop. Take care of yourselves. Bye bye.